good morning, good afternoon, depending on your geographical location in the United States. My name is Eddington Tudee, and I'm a family nurse practitioner pursuing my doctoral degree in nursing here at the Maryville University. The title of my project is The Effect of Non-Pharmacological Management of Adults with Type 2 Diabetes. My committee members include Dr. Don E. Matz, course faculty, Boniface Steckman, a community member like the Grace A.B. Toto. Now let's talk about the background and significance of type 2 diabetes. Type 2 diabetes is characterized by insulin resistance and impaired insulin secretions, which leads to an increased risk of macrovascular and microvascular complications like eye disease, which leads to vision loss, kidney disease, amputations, peripheral artery disease, peripheral neuropathy, and stroke, heart attack, etc. Diabetes. In the United States alone, more than 34.2 million people live with diabetes, which represents 10.5% of the entire population, with most cases being type 2 diabetes. That was noted by CDC. Now, obesity, sedentary lifestyle, improper diet, and weight gain contribute to insulin resistance, thereby increasing the development of type 2 diabetes. Now, while pharmacotherapy is essential, structural lifestyle interventions like diet modifications and physical activities can improve glycemic control. The reason this project was set up was because that we noticed some gaps at the clinic where I worked. The lifestyle programs were underutilized in routine care due to poor educations, follow-ups, and workflow barriers. So I set up as an aim or objective to operationalize non-pharmacological management within routine diabetic care to improve hemoglobin A1C and fasting blood glucose over the period of 3 months. Review of the literature. Now, structure, nutrition, and physical activity are the foundation of glycemic control in type 2 diabetes. And multiple studies across different settings has reinforced that. Structured lifestyle programs that combine diet modifications with physical activity yield meaningful improvement in both hemoglobin A1C and fasting glucose. Now, what does the evidence show? Ahmed et al. 2020 demonstrated that a structured dietary program plus prescribed physical activity leads to statistically significant reduction in hemoglobin A1C and fasting glucose compared with usual care or pharmacotherapy. Rastogi et al. 2024 added that lifestyle and modification tailor individual risk profile improves glycemic measures and metabolic parameters in diverse populations. So Namsarin et al. 2019 finding shows that early evidence that combined diet and activities focused intervention produce durable improvements even in real-world non-trial settings. The American Diabetes Association supported this by providing actionable evidence-based dietary activity guidance to support patients with type 2 diabetes. Perez et al. 2021 noted that although exercise is effective in managing type 2 diabetes, matters for adherence. So a progressive individualized exercise plan improves adherence safety, and glycemic outcomes. Finally, David et al. 2021 emphasized that gaps in education, delivery, follow-ups, and integration into pathway limits the effectiveness of lifestyle intervention. So consistent patient educations, consistent follow-ups with patients, progress tracking of patient activities, and inclusion of multidisciplinary coordinations can improve uptake and the effectiveness of lifestyle interventions. The theoretical framework that guided this project is the PDSA, the Plan, Do, Study, Act Circle. The PDSA is a four-step cyclical method used for continuous quality improvement across healthcare, education, and other domains. For the plan or the P, I identify an improvement area which is poor type 2 diabetes outcomes, and I design a lifestyle intervention of diet and exercise program. The do, D, together with my team, we implemented a routine checks in the clinic setting related to the project. The S for study, I monitor glycemic outcomes, hemoglobin A1C, fasting glucose, and the understanding of diabetes knowledge of questionnaires by the participants. And the A for act, and it was done by the team refining strategies for feasibility, scalability, and sustainability of the projects. Now, the method and designs that were used for this project. This quality improvement project was conducted at a Midwestern United States clinic that served a diverse population. Diversity was a strength in this project because it enabled us to observe effects across different ages, ethnicities, and socioeconomic backgrounds. The design that we use is a quality improvement with a pre-post design. This type of design is well suited to detect changes within patient over time in hemoglobin A1C, BMI, UACR, and diabetic knowledge questionnaire scores when randomized controlled trials are not feasible in a quality improvement project. The study used a retrospective chart review, collecting data at 2 points before the intervention and after the intervention. The pre-intervention was with 2 and 3 of the interventions period, and after 3 months post-interventions, where we measure whether the implemented diet and exercise program correlates with improvement in clinical outcomes of type 2 diabetes. Data collection point again at baseline and 3 months follow-up hemoglobin A1C, BMI, UACR, and self-management feedbacks. How do we analyze the data? Usually in these quality improvement projects, non-parametric t-tests are used, but because the sampling was abnormally distributed, we use what they call the Wilcoxon rank t-test was used. Sample. Descriptive statistics were used to summarize the data. Now, descriptive statistics are numerical information that summarize and organize data from quantitative studies. At the beginning, we had like 40 members, but 2 drop up, and we end up with 38 participants. The demographic variables include sex, age, and race, and lifestyle factors, adherence to diabetic diet, and the level of exercise. The race distribution included 13 whites or Caucasian, 16 blacks, 8 Hispanics, and 1 Asian. The general distribution was 42.1% male and 57.9% female. Data analysis. Primary outcomes. Each participant pre-intervention values were compared with their post-intervention value for hemoglobin A1C, UACR, and BMIs. Statistical tests. The Wilcoxon sign rank tests for hemoglobin A1C, UACR, and BMI all shows statistically significant differences between the post and pre-score. The hemoglobin A1C z-score of -5.38 and the p-value of less than 0.001. The UACR z-score equal -5.178 and the p-value of less than 0.001. The BMI has a z-score of -5.373 and a p-value of less than 0.001. Now, for the hemoglobin A1C, the negative Z indicates that post-hemoglobin A1C values tended to be lower than the pre-hemoglobin A1C values, indicating an improvement, and the median difference confirms a reduction in the hemoglobin A1C post-interventions. For the BMI and UACR, the negative Z likewise suggests that post-intervention BMI and UACR values were lower than the pre-interventions, indicating improvements in weight and albuminuria rates, with the median difference supporting a reduction. Data. I'll go to the results. A statistical significant change from pre to post intervention was observed across all three outcomes: the hemoglobin A1C, the UACR, and the BMIs from retrospective chart reviews. Results from the Wilcoxon sign rank test show statistically significant improvement in all measures. Outcomes that decrease post intervention of a p-value less than 0.001 for each. The negative Z value indicates, given the table's data orientation, that most participants experience improvement in glycemic and renal risk matter, as well as weight reduction post-interventions. The mean diabetes questionnaire score rose from 32.7% pre-intervention to about 68.4% post-intervention, a gain of roughly 35.7%, indicating that the understanding of the participant of the diabetic notice questionnaires. I'll go down to the limitations. Some of the limitation was the retrospective chart review, which could pose a potential oscillation bias, especially without a randomized assignment. Differences in outcome may be due to underlying differences, age, and comorbidities, medications, rather than the real interventions. The sample size was a little smaller, which could limit the generalizability and diminishes statistical power. Also, there was a short follow-up period of 3 months, which could hinder the long-term sustainability of lifestyle interventions. Potential confounders, not control, like medication changes and socio-economic factors, will all bring about limitations of the project. Data completeness and self-report bias in the diabetic notice questionnaire could pose a potential bias. Now, these identify weaknesses, compromise the interpretations, applicability, and reproducibility of the findings, underscoring the importance of adopting rigorous research practices. Discussion. The finding of this DNP project indicates that non-pharmacological management of type 2 diabetes, such as structured diet, modification, and physical activity, can meaningfully improve glycemic control and reduce cardiovascular risk factors in adults with type 2 diabetes when consistently implemented and tailored to the patient. While pharmacotherapy or usual care remains essential for many patients, integrating lifestyle interventions has been shown to improve hemoglobin A1C, the body mass index, blood pressure, UACR, and the quality of life. Some of the barriers identified included variation in patients' motivations, limited access to resources, socioeconomic constraints, and limited health literacy, which underscore the need for multidisciplinary team, culturally tailored education, ongoing training, and scalable support system. These findings support a pragmatic, patient-specific approach that prioritizes adherence, feasibility, and sustainability while highlighting areas for future research and differential impacts of specific non-pharmacological management across diverse populations. Implication for practice. Nurses are central to translating non-pharmacological diabetes care into sustained outcomes by leading lifestyle interventions, using motivational interviewing, and coordinating cross-disciplinary support to overcome barriers like health literacy and resources access. Nurse-led programs that emphasize tailored diet and activity changes with ongoing coaching can improve glycemic control, which underscore the nurse's role in personalized planning and progress monitoring. Nurses also drive system improvements through culturally tailored education, streamlined referrals, scalable remote training to boost adherence and equity. Now, by integrating these practices into primary care, they support lasting behavior change and aligns with guidelines that position lifestyle modification as a core diabetes management strategy. Conclusion. The personal impact of DNP programs. The Doctor of Nursing practice has transformed my approach for individual patient care to system-wide improvement. I have moved from beyond direct care delivery to actively shaping care teams and pathways. This means designing and guiding care models, coordinating multidisciplinary efforts, and ensuring that my workflow supports safe, efficient, and high-quality patient care. The key learning from the DMP education is that my GMP journey has equipped me with the leadership, methodical rigors, and collaborative mindsets needed to drive meaningful, lasting improvement in diabetes care and beyond. I'm excited to translate this competency into further advancement for patient care. Conclusion continues. The personal impact. Okay. To truly understand diabetes outcomes, we must redesign systems, translate evidence into everyday practice, and lead multidisciplinary team with a clear future-facing plan. System-level leadership by nurses, align policies, formalize evidence to practice processes, and interprofessional collaboration paves the way for lasting health improvement. At this time, I will come to the end of my presentation. My references are here for all to view. But before I end, this presentation, I want to express my heartfelt gratitude to Dr. Dawn E. Matz for her guidance throughout the DMP program. I'm especially grateful for her insightful mentorship and immediate feedbacks. I want to also thank all the instructors, including Dr. Stegman and Dr. Sarisa Moe, including our statistician, Dr. Paul, for helping me shape this project. Lastly, I want to thank Dr. Grace A.B. Toto for her mentorship and making sure this project came to fruition. Thank you very much for your time.